And without further ado, I would like to introduce Dr. Allan Jordan. He is the Director of Oncology, Drug Discovery at Sygnature Discovery, and he'll be doing a talk on current personalized medicine strategies, provide limited clinical benefit. How do we do better? Allan, over to you.
Thank you very much, Lewis. Good morning, good afternoon, good evening. As Lewis said, wherever you are in the world, thank you for having me along for the meeting. For those of you who don't know, let me just share some slides. Let's give you a, sorry, excuse me a moment. We just need to get the slides up. For those of you who don't know Sygnature Discovery, I'm just going to spend maybe 1 minute just giving a very quick introduction to Sygnature Discovery. We're the UK's leading provider of integrated drug discovery services, both in the both in the oncology therapeutic area and beyond. Our oncology offering has been strengthened over the past few weeks with the acquisition of a very specialist niche in vivo oncology services provider that works in oncology and immuno-oncology. But actually, I don't want to dwell too much on Sygnature and who we are. That's a conversation that I'd be happy to have with any of you on another day, because actually, I think what we want to talk about today is something much more important, and that's this. Are we actually getting oncology drug discovery right? I'm going to focus predominantly on small molecule drug discovery, but I think a number of the topics that we're going to discuss today are applicable to large molecule oncology drug discovery as well. I think they're generally applicable themes. So let's take a moment of reflection. It's nearly 50 years since President Nixon signed into US law the US Cancer Act, the so-called War on Cancer. And there's been a lot of debate recently in the journals and in the popular press as to whether that war on cancer has actually had any effect. And if you look at publications from, say, Cancer Research UK over here in the UK and also the AACR in America, it looks like we're actually having a tremendous effect on cancer. Seeing in the US alone increase in survival from 3 million back at the start of the war on cancer to 16.9 million survivors now, 26% reduction in US cancer death rates, and increasing survival over here in the UK from 1 in 4 in the 70s to 2 in 4 today, and the plan to increase that to 3 in 4 and beyond. And small molecules have had a significant part in that. If we look at data that was presented in the New England Journal just tail end of last year, if we look at chronic myeloid leukemia, we can see that over that 50-year period, the incidence of CML has actually remained unchanged, but there has been a significant decrease in mortality if you look at the rates of incidence per 100,000 patients. And if we normalize that back to the rate relative to 1975, that decrease in mortality looks even more significant. And most of that has been due particularly to drugs like Gleevec, imatinib, where it's that single agent drug has reduced mortality rates, has increased overall survival rates from perhaps 6 months to 30 years plus now in that disease. And really, that's happened with a number of small molecule agents. You could argue it's happened with imatinib. It's also happened with drugs like tamoxifen in breast cancer, which was discovered not 200 yards from where I'm sitting right now at Alderley Park, just on the south side of Manchester. So they're the success stories, but for most cancer patients, actually that situation is completely different. So let's look at lung cancer, for example, and this actually is the norm rather than the exception when looking at different types of cancer. And you can see very clearly that mortality rates and incident rates track in parallel. So whilst incidence has fallen, particularly with better lifestyle choices, reduction in environmental pollutants, reduction in smoking, the mortality rate tracks almost completely with incidence. What that means in a nutshell is that in lung cancer and in many other cancers, our small molecule and large molecule therapeutics are actually having no effect whatsoever on mortality rates. We are not actually giving meaningful increases in survival to the patients that we seek to treat. So how do we rationalize that? How do you rationalize that we've seen an increase in overall survival allegedly from the cancer charities, but our mortality rates are not increasing? And I think part of it is statistics, and to really understand what's going on with statistics, we really need to think about something that we tend not to consider in drug discovery, and that's the actual journey that a patient goes through when they're diagnosed with cancer. So let's take a standard patient. Let's genericize our patients and maybe take a patient who's got lung cancer. So perhaps that patient presents in a cancer hospital or a diagnostic center, their cancer is diagnosed and staged, and ideally, in the ideal world, it's caught early and they only have a primary tumor detected, and that tumor may be operable. So maybe that patient goes through surgery and then through adjuvant chemotherapy to remove any residual traces of disease, and then that patient is into a worrying cycle of watch and wait, and then maybe after a few years, they're classed as being cured. But for most patients, that's not the case. Many patients present with either an inoperable primary tumor, or they present with metastatic or high-risk tumor, and then surgery or radiotherapy, our two main curative techniques, are options to them. And that's where our chemotherapeutics and targeted therapies come in through first line, second line, third line, nth line therapy, until finally they run out of treatment options, resistance becomes embedded, they're into palliative end of life care, and then ultimately that patient dies from their disease. And that entire process, some patients also on that watch and wait category, they also relapse, and they either relapse with local disease or metastatic disease, and then again they're into first, second, nth line therapy, ultimately through to the point where our treatments stop responding for them. As the patient moves through that journey, they become increasingly drug resistant, increasingly less sensitive to the drugs that we're trying to develop for them. But that overall process they go through, from initial diagnosis and cancer staging through to the point where they succumb to their disease, is what we define as overall survival. And I think this is where a lot of the problem with those metrics comes in, because by defining that overall survival from point of diagnosis to the point they succumb to their disease, simply all we have to do is diagnose their cancer earlier to significantly increase their overall survival. Doesn't mean that patient survives any longer, they still die at the same point in physical time, but they knowingly live with their disease longer. And what we've seen, I think, over the past 50 years is not an increase in true lifespan extension through our treatments, but what we've seen is an increase in that lead time. Patients know that they have cancer for longer, but actually we're not providing meaningful increases in their overall survival. Where we really need to get to are the two bar graphs below, where we're actually providing a meaningful prolongation of their life. And I would argue that, except for examples like imatinib and tamoxifen and perhaps a few other smaller cases, we're really not providing cancer patients with the benefits that we perhaps claim we are. So how do we get better? How do we improve that? And how do we deliver outcomes that are better for our patients? And I think there's a number of ways we can do that. And the four that I'd like to discuss with you and share with you some thoughts on today are in CNS oncology, overcoming resistance, better delivery systems, and also thinking perhaps more creatively about some of the alternate drug targets that we're starting to see come through. So firstly and briefly, CNS oncology, and here I'm not talking about diseases of the CNS specifically like glioblastomas or astrocytomas, but more systemic cancers that migrate to the brain. And this was a statistic that shocked me the first time I saw it, that 1 in 3 of our patients who die with cancer have brain metastasis at point of autopsy. They are carrying metastatic disease in the brain. And actually, for particularly diseases like lung cancer and breast cancer, where our systemic treatments have improved significantly, more and more patients are dying of brain cancer. They're dying of secondary disease in the brain, causing ultimately systemic organ failure. And yet we are not seeing an increase in CNS penetrance in the molecules we design. We're not taking into account brain metastatic disease as part of one of our primary drug design criteria. Because most of the recent oncology drugs that have gone into the clinic and have gone on to be FDA approved are poorly CNS penetrant, which means that we're almost predisposing patients to die from CNS metastatic disease. So I would argue we need to think significantly more proactively about delivering more brain penetrant compounds in drug discovery and ultimately through preclinical drug discovery and into the clinic to help those 1 in 3 patients for whom we're predisposing to death by CNS disease. I'd also argue we need to think much more creatively about overcoming resistance. We know that single agent therapies fail, but why is that? Well, it's largely because of the way we structure our drug discovery programs. And I would argue that our cancer drug discovery model has tended to focus on single genetic drivers. And in some examples like CML, with Gleevec, for example, that's worked very well for us. But that rush towards other single molecularly targeted agent has been less successful. So we take, for example, EGFR mutations in lung cancer, and we structure our entire campaigns around that single mutation. So we identify EGFR as driving cancer progression, and we build an entire screening cascade of enzyme and cell and in vivo assays to replicate that single monogenetic alteration. And so it's hardly surprising that when we take our potent selective agents through into in vivo studies, they show phenomenal activity that is simply not reflected when we move into clinical trials. And that's because those monocultures of homogeneous, consistent cell populations simply do not reflect what we see in the clinic. And I think a really good example of this was published back in 2010 from the Vogelstein group, where they examined a pancreatic cancer. This was a gentleman who had his pancreas excised as part of his cancer treatment and donated his pancreas back to the research group. And they sectioned his pancreatic tumor into 17 different sections and undertook whole genome sequencing of each section and found that each section was genetically unique. So what that means is that patient didn't just have cancer, and he didn't just have pancreatic cancer, but he had at least 17 genetically differentiated, unique types of cancer all at the same time. And with that genetic heterogeneity, it's hardly surprising that our single molecular targeted agents are failing. But more worryingly, because of the way cancer emerges and cancer evolves and the way we diagnose our treatments and the stage at which we diagnose our treatments, that genetic heterogeneity is already instilled and inset at the point of diagnosis. So resistance isn't something generally that is a result of our drug treatment. It is intrinsic at the point of intervention. There's almost a mathematical certainty that those patients will fail on any single targeted molecular agent. Now, we've made some headway to understanding that, and I think we are moving things forward with combination therapies, such as, for example, the RAF inhibitors and the MET inhibitors in melanoma used in combination to give much more durable therapeutic benefit. But again, the way we design our molecularly targeted agents is to dose at maximum tolerated dose to get a maximum biological effect. And I would argue we've sort of got almost lazy in the way we design our molecules, and we tend to design our molecules that they only have maximal effect at doses which are also just on that cusp of intolerable side effects for the patients. What that means is to dose two of those agents in combination to overcome drug resistance means that we have to dose reduce to manage side effects, and more often than not, those doses reduce to subtherapeutic levels. So we give patients all the side effects, but no biologically effective dose of our drug. And again, I would argue we need to be much more creative and much more thoughtful about designing our agents to be much better tolerated, where we have a much more significant window between clinical side effects and biologically effective dose, so we can much more effectively combine those agents together. I do think we need to diagnose earlier as well. I think earlier diagnosis, as I mentioned earlier, is what's caused that perhaps artificial increase in seeming overall survival for our cancer patients. But if we're going to tackle that genetic heterogeneity, we need to know patients are suffering with cancer much, much earlier, perhaps 2 to 3 years earlier than we're diagnosing at the moment. I think it's surprised of how slowly cancers grow and evolve. It can take many years, in many cases, for example, pancreatic cancer, 20 to 30 years from that single initiating event before a cancer becomes detectable. But they're not detectable until they're around 10 to the 8 cells. But the genetic analysis of many tumors shows that that heterogeneity and intrinsic drug resistance happens at about 10 to the 6 or 10 to the 7 cells. So a 10 to 100 times fewer cells than a tumor that we can detect. So are there ways we can work as a drug discovery community with our diagnostic colleagues and our imaging colleagues to get much better at cancer diagnosis, perhaps diagnosing cancer maybe from a blood sample, a stool sample, or other bodily fluids before the patient even knows that they're carrying a tumor within them. We're doing that in some tumors much more proactively, but I would argue we need to do that much more dramatically in more tumor types with more accuracy, more specificity, and in a way that's less invasive. We've tended to rely purely on tumor biopsies, but tumor biopsies do carry with them an intrinsic clinical risk, and in some cases, those biopsies can lead to patient death. So I do think we need to think more creatively about how do we sample tumours in patients to diagnose earlier before that resistance is set in, where our molecularly targeted agents and perhaps our therapeutic antibodies may be much more effective. I'd also argue we need to think better about how we deliver our agents to patients. I think, again, we've tended to fall into this idea of once or twice daily dosing with very high Cmax and a relatively short half-life. That means that the doses our patients see are very spiky, and it's very difficult to maintain biologically effective doses of our agents before we go above the maximum tolerated dose. If we could have much more linear PK, either through better formulation or better delivery, then perhaps we could keep our doses just above that minimum biologically effective dose, and without spiking exposures above the maximum tolerated dose and leading to those grade 3, grade 4 adverse events that so many of our patients experience. So maybe we need to think again about how we deliver our drugs. Maybe an oral tablet is not the right way, or an IV infusion. I think we tend to forget about alternate delivery methods such as implants. Casodex for prostate cancer is a great example, I think, where patients receive a subcutaneous implant once every 3 months. And that gives them a drug at biologically effective dose with minimal side effects, and they only need to be treated once every 3 months as an outpatient visit. We tend to think about transdermal patches for things like pain relief or nicotine supplementation for smoking cessation, but we tend not to think of them for other diseases such as cancer. But are there other medical devices? Are there other ways we could deliver those drugs to our patients? Maybe oral inhalation for lung cancer, for example. I suspect there are better ways where, if we work with our device engineers and our formulation experts, there are better ways of delivering the drugs we already have and our next generation agents to give more uniform dosing above that critical biologically effective dose, but below the minimum tolerated dose where we start to see those side effects. And I wonder whether perhaps at future preventer meetings we should be engaging and getting those device experts and formulation experts much more involved in these partnering meetings to understand how they can help us take our projects forward. But as a research community, I would argue we need to think more creatively about our drug discovery targets. I think there are better ways of killing cancer cells, and I think we need to be more imaginative at finding better points of intervention in terms of how do we treat cancer. I think there are probably more diverse treatment options that will allow us to overcome some of those resistance issues and perhaps also some of those dosing issues that I've already referred to. And I think we tend to suffer from what we've been tending to call the PD-1 or the PD-L1 syndrome, and I think that's summed up beautifully in this cartoon, which is once somebody comes up with a great idea, rather than congratulating them on a great idea and wondering how we can do something that complements it, we tend to follow the crowd and pursue the same therapeutic strategy. What that means, and just looking at the PD-1, PD-L1 trials at the moment, this slide is already out of date. There are now around 2,500 trials of PD-1 and PD-L1 antibodies going on. In the Western world alone, that requires over 400,000 patients per year just to run those clinical trials in that one particular drug target alone. And these trials are suffering. These trials are suffering because they simply cannot recruit enough patients to fulfill all those trials. And I would argue that the nuances that we're now investigating in those antibody trials are probably unlikely to deliver further significant patient benefit over the trials that have already been conducted and have led to the approval of some of these agents. I would argue this approach is unsustainable and really is only generating minor changes in patient benefit now. And I wonder if we need to move away from this Me Too approach into more inventive targets. But I would caution as to where those targets come from. I think it's fair to say that most new emerging targets come from the literature, such as papers like this. This isn't a true paper from Nature. This is obviously just an example to make the point that we see these driver mutations reported generally from single labs. And we try to take those forward, and more often than not, those target validation experiments that we do internally tend to fail to reproduce the literature findings. And that was replicated by both Amgen and Bayer in this paper that I think was really set the scene for biological reproducibility and replicability of new targets in a way that can support drug discovery. And these industry studies suggest that perhaps only 1 in 5 new biological targets emerging in the literature can be validated in a way that supports the data rigor and the data integrity that we need to support a 3 to 5 year drug discovery program. So perhaps we need to be better at target validation. We need to be better about our biological reproducibility and ensure that the targets that we do take forward really will have patient benefit. And I think that's a key factor, because I think in much of our target validation, patients are something that we don't think about. We look at the biological reproducibility and perhaps the CRISPR knockouts and how we can modulate that target with small molecules. But I wonder whether we're being rigorous enough in asking whether those targets stand up to significant clinical scrutiny. Do we believe there is a truly identifiable patient population who will benefit? Are we trying to treat a disease that is already so ingrained that our treatment won't actually have any effect if we manage to get through all the hurdles of drug discovery and bring it to the clinic? And do we stop to ask whether we can find that critical phase 1 patient cohort, knowing that they will be heavily pre-treated, probably highly drug resistant? Do we have appropriate patient selection criteria right at the start of our drug discovery programs to make sure that we can truly test that biological hypothesis in the clinic? And even if we do all this at the start of our programs, I think we often forget to continue that process of target validation as we move through the pipeline. And I think it's a fair comment that target validation has to be an ongoing process, and a target really is only truly validated once there is a drug approved on the market, successfully treating patients and giving them a meaningful benefit, meaningful extension in their life expectancy. And I would raise here perhaps the forgotten target patient population, because I think, again, we think about adults. It's fair to say that most oncology clinical trials tend to be conducted in white adult males over the age of 65. There are a number of patient populations that we exclude, certainly from those phase 1 clinical trials. But I would argue, perhaps quite emotively, that we also forget about the children. And I think children and pediatric cancer care is something that we frequently overlook. There was a really good session at the AACR virtual meeting only a couple of weeks ago on exactly this. And I'd certainly encourage people to go and listen into that and maybe think about how we extend our clinical trials and our drug discovery programs for pediatric medicine. There are over 1,000 investigational cancer therapeutics being studied in the clinic and preclinical development at the moment, but less than 10 of those are being considered for pediatric clinical trials. We've not seen any meaningful improvement in childhood cancer rates over the past 20
I think we might have lost Alan's sound, so we'll wait for a minute or so and see if he can come back in. But I think he was just wrapping up the last slide or so. So if there's any questions that you would like to send to Alan, it would be great if you could put them in the chat or the Q&A, and we could get Alan to follow up. Oh, he's back. Alan,
I apologize for that. We're back. Yep.
Good. All right then. Perfect.
Yeah. Let me go back to the screen share. I apologize for that slight interruption in service. Hopefully normal service will now be resumed. So whilst we look at those childhood cancers, while they maybe look different from a histological point of view, actually those children's cancers can carry many of the same drivers as we see in adult cancers. So perhaps we should be a little bit more pragmatic and maybe a bit more proactive about thinking about how we treat cancers in the pediatric setting. So I'm aware that's all rather gloomy. That's a rather gloomy outlook as to where we are, and would suggest that we're not making particular impacts in a number of tumor types. But I think there is cause for optimism. And I think some of the treatments that we're starting to see come through now give us cause for optimism, but also set a new bar for where we need to be in terms of delivering cancer treatments. So I guess many of you who are joining the call today will never have heard of cholangiocarcinomas, salivary gland cancers, or infantile febrile sarcoma. And that's hardly surprising, because here in the UK, these are the number of cases we see each year. Infantile febrile sarcoma is particularly rare, with only 4 cases a year. And you can contrast that with, say, 63,000 cases of lung cancer and 55,000 cases of breast cancer. But these rare diseases can often be grouped together, not from a histological standpoint or a biological standpoint, but from the drivers that they carry. And the underlying factor in all of these cancers is they all carry NTRK fusions, and they carry related gene activating fusions, irrespective of whether it's TRK-A, TRK-B, or TRK-C that's driving that cancer. And we've seen over the past few years the delivery of a number of inhibitors, such as larotrectinib here, which is a pan-TRK inhibitor, which has also been designed to address potential likely secondary mutations that would lead to resistance. It inhibits all members of the family, and interestingly, it's also been formulated as a syrup such that it can be dosed to children, particularly for those infantile sarcomas. Very few side effects. I think the tolerability profile of this sets a new bar for where we should be aiming with targeted therapies, and very few significant, very little discontinuation in the clinic. And yet, despite all that, despite that fantastic design, the drug is incredibly effective. For the vast majority of patients who carry a TRK fusion, this drug gives significant prolongation of life. This is data presented at ASCO and ESMO over the past few years. It doesn't matter where your cancer is in the body, as long as it carries a TRK fusion, it tends to respond to that particular drug treatment. And I think these agents, such as larotrectinib and the TRK inhibitors, set a new standard for where we should be aiming our new therapeutics, small molecule or otherwise, because these agents are exceptionally well tolerated. Their PK is exceptionally well controlled. They have incredibly well tolerated side effects. They're very highly orally bioavailable. They lend themselves to multiple delivery routes and multiple formulations. They're designed from the outset to be CNS penetrant and deliver clinical benefit against that CNS metastatic disease. They're designed to combat already the upfront likely resistance mechanisms that are predicted to emerge in the clinic, and they work across multiple disease types, genders, ethnic backgrounds, and ages. They are truly a population agnostic approach to a significant unmet clinical need. And going right the way back to the start of the talk, most of our targeted agents maybe give a response of 3 to 6 to 9 months. There are patients on these inhibitors for significantly longer than 4 years. We are truly starting to deliver meaningful benefit to those patients who carry a TRK fusion. And I believe this is the sort of standard of care we should be aiming for our next therapeutics. Because I truly believe, and at Sygnature, we truly believe that the patients we seek really deserve a true increase in their overall survival. Not an artificial one from statistics through to earlier diagnosis, but actually to live much longer and to die much later than they would have otherwise done. I think to do this, to accomplish this, we need a more integrated, a much more holistic approach to deliver this benefit. I think we need much more clinical insight. I think we need to better understand how we position our drugs and think more creatively about how we structure and design that path to clinic, right the way from target validation through hit ID, lead optimization, and preclinical drug discovery. And I really think that as a community, and I think meetings like this help with that, we need to engage much more widely as a community to deliver real step changes in cancer care so that our patients live significantly longer and truly feel benefit from the medicines we're delivering. I hope that's been thought-provoking. I hope that's perhaps raised some questions, and clearly all of us here at Sygnature Discovery really believe that our patients deserve better from the drug discovery community, and we'd be very welcome to have conversations around how we can perhaps help work with you to deliver some of those benefits in the near future. Thank you.